Hello and welcome. Moving forward to our post-lunch session, there is a debate on robotic versus laparoscopic. Where do we stand today in minimally invasive GI surgery? I would request our chairpersons, Dr. Patta Radhakrishnan and Dr. Madhusudhan, to please join us on the stage.
Good afternoon and welcome to this post-lunch session, important session about robotic versus laparoscopy in minimally invasive GI surgery. I remember the early 90s, mid-90s, when there used to be a debate about open versus laparoscopic surgery, a huge debate, and every time I used to hear Dr. Nandi, Dr. Rangabhasham speaking in favor of open surgery versus Dr. Chaube on laparoscopic surgery. Now much water has flown under the bridge. Now we have come to a stage where we're debating whether it's laparoscopy or versus robotic surgery. Robotic surgery has started coming into our milieu slowly, and if there's one point of contact in India for laparoscopy is Dr. Palanivelu, and one point of contact for robotic surgery is Dr. Jagdishwar Gaud. And there can't be a better faculty to debate this topic. And to start, we have Dr. Palanivelu, the pioneer of laparoscopic surgery in India. He will be speaking from his abode today, and over to you, sir. Good afternoon, sir. Can you hear us?
Radhakrishnan?
Yes, sir.
Yeah, there is a recorded play will be there. Huh?
Yeah. Oh, you have to play the recording of this.
Ask them to play the record. It is already is there.
Okay.
Otherwise, I will to speak.
Can play the recording.
Good afternoon, friends, dear chairpersons, organizing committee members, particular organizing secretary Sanjay Mondal, and my friend Jagdish Gaud, the debater for robotic, and young surgeons and faculty friends. And I sincerely thank the organizing committee taking this great subject as a debate in GI surgery, laparoscopy versus robotic. And I'm sharing the slides. I'm going to talk for laparoscopy surgery and GI surgery. I'm a gastroenterology surgeon. I do open surgery, I do laparoscopy surgery, I do robotic surgery. Just because I'm going to talk about more for laparoscopy does not mean I'm against robotic surgery. I'm also doing robotic surgery. I've done almost all the procedures. In fact, robotic esophageectomy, Whipple's won international awards for the best operative technique. And currently, the laparoscopic surgery is the most commonly used procedure, and robotic surgery has got limited indications. And when we go laparoscopic surgery, we should have some advantages. One is, it should be cost effective, affordable to all socioeconomic strata group. Then only we consider it as success. Simplifying the operative technique so that even general surgeons can take up in clinical practice with improving safety. Quality of life after surgery should be better in terms of wound-related problems or functional disturbances, and faster recovery should get back to routine life or work. And also, if you go for cancer, oncologically, it should create more successful than the today compared to open. Immune preservation because avoiding laparotomy and avoiding blood transfusions. Also, these people can go for early chemoradiation so that by which the patient have a improved survival and reduced local recurrence. Learning curve only is a question comes between laparoscopic robotic, and robotic group, if you ask, they will say easy to learn, easy to switcher. I don't know, I don't want to listen that word easy to learn anything. And if it is going to be very effective to the community, we should put hard work, learn the best to do it. Laparoscopy is not that difficult provided if you learn commitment. Robotic surgery is not that easy as you all think. Probably like a car driving in the beginning, learn the driving may be easier, but you want to become an expert in car driving, then you have to put it more effort to self-learning. That way, robotic surgery, complex operation is difficult as to learn like a laparoscopic surgery. There is a technological advantages like we have a magnification of the angle of view, and we have energy sources plenty available. More than robotic, we can do a blood dissection. For example, if you do a liver section, today in World Congress in Japan, they said liver surgery, laparoscopy is more favored because the way the QSA has been involved in liver section. We can do without QSA as well, no doubt about it. But comparison-wise, World Forum recommended laparoscopy liver section is the best way. And instruments, I agree that it is entrant dexterity, but I will say laparoscopy instruments are more slimmer. You can use 5 mm instrument, you can 3 mm instruments, you can use a 2 mm instrument. Also, and the tip may be a limited flexibility, but what we need, and 99% of the cases, limited movement is enough, except that enhanced heuristic movement only for narrowed spaces, delicate structured suturing, like a limited. I also agree there robotic may be useful. And rotatable, here also rotatable is there. And tissue identification, for example, if you have cancerous tissues, delicate tubular structures, and those or anomalous vessels can be easily identified using ICG. Both exist in laparoscopy as well as robotic. And tremor filtering effect robotic, they say, I agree with that. But if you properly placed in why the tremor, part of the trocar, partly with the instruments and programmed. Here is not a program, but if you use 5 mm instrument, 5 mm trocar, you can see the tremor is lesser. And opposite movement may be one factor, but by learning, we don't know the tip moves opposite not. It is typed in the brain, automatically instrument moving, there is no problem. And by experience, we learn how to get a wider exposure and improved reconstruction techniques. Now we don't see much of leaks or strictures. And by avoiding laparotomy, maximum, we can take it a suprapubic incision or nose procedure through anus or through vagina. So you can use a single incision, and right now there is robotic single incision, fine, but you should have a cost-effective involvement, capital investment, much more to do it. But laparoscopy, you learn, you can do a single incision for a gallbladder or simple surgeries. It is cosmetically better, and I will show later. The problem in the beginning, laparoscopic suturing, difficult. It is the beginning, that they were using skin needle. They were started suturing, very difficult, cumbersome, no doubt about it, for reconstruction. But when I showed in 1995 at Luxembourg, gastrojejunostomy, stump closure, difficult gallbladder, and type approach peritoneum, all, it is like a regular open suturing. Many of you seen that I am showing. Why I am able to suture? Because I chosen the regular conventional needle placed inside the abdomen, started suturing. The world first time looked at me at Luxembourg, then they started learning. So that time the type difficult to suture, difficult, still continuing. I don't know. I'm doing reconstruction, suturing, 2 mm pancreatic duct anastomosis, duct mucosa, everywhere. I compared robotic laparoscope. I feel it is okay, but maybe a delicate level, certain places robotic may be useful. But look at a surgical practice and appendicitis, hernia, and if you take it a simple gallbladder down to the perforated gallbladder, GERD, hiatus hernia, achalasia cardia, cyst in the abdomen, and splenectomy, and procedures. These are all today, laparoscopy is the standard of care. And only the most important, you want to make a successful, train the team, staff nurse and the assisting surgeon, that is much more important. And then learning curve, as I already mentioned, they say robotic surgery is difficult, easier and this. And I already mentioned, basic is easy to learn robotic maybe because it is programmed, is given. But none of us were taught laparoscopy that seriously with the simulation, everything. Now, even we have a simulation for laparoscopy, we have a robotic. Surgeons should adapt their mind to learn the proper, should not just thinking one day we can go and see one operation, come and do second, third, started teaching. That was the problem, laparoscope. Otherwise, see, robotic surgery came, it is not now, it is again lasted more than 20 years in clinical practice. Today, still today, the number of procedures done, indication-wise or no total number-wise, still laparoscopy is the ruling it. And take it a gallbladder, difficult, any gallbladder, simple. And if you use, we do 99% of the cases not even the cost of the laparoscopic robotics instruments. Just cheaper you can do any difficult gallbladder. Only the problem we have to learn is suturing. That part you can see. This is acute gallbladder, perforated one, and you can see cystic duct here. And I taking this. You take the suturing. You can't put a clip. You can't put a stapler. You can't put a loop. So this where this we learn, and we practice, and become so much more this. And this subtotal modified cholecystectomy, we even did a PhD study in our own center. Dilip Gode was the first candidate from Nagpur, and it is all the way we learn. And GERD increasing, very highly increasing, last 25 years. Once it was Western disease, now it is much more. So we need to look at hiatus hernia associated GERD, which is refractory to medicine. Patient has got a complicated Barrett's. That laparoscopy fundoplication is the gold standard today treatment. Large hernia, giant hernia, immaterial, redo, everything can be done well. Achalasia, cardia is another important thing. We did the world first in adult, and it can be, Hellas can be done, dysphagia can be relieved. Toupee or dorsal, depending on the center, one can practice it. And only the difficulty is people call a mucosal injury, and for which, and as you can see, I designed this achalasia myotomy scissor, and it's got a boot. You can use energy, cartridge, without mucosal injury, and you can continue that way. It is possible. That is not there in robotic, and if you, this kind of things, see, this you can see that mucosa is spared from this one. And another important point, short esophagus, we can extend a dissection to the mediastinum can do. We can, neo-esophagus, we can reconstruct it. If a sigmoid esophagus, even a transhiatal esophagectomy can be done well, and with this, and that way transhiatal still laparoscopic is a better way to doing it. When 2001, when I showed cancer operations, one is total gastrectomy, another transhiatal esophagectomy live, everybody surprised to see that time. Kim from Korea showed a right colectomy and resection. Since then, now this has become a specialty, new specialty, minimally invasive surgical oncology, and even a GEM hospital has been recognized for postdoctoral fellowship. And for this, here, RO resection rate is better in minimally invasive than open, and local recurrence reduced, and improved bloodless dissection by avoiding blood transfusion, laparotomy. And early chemoradiation also improves survival. And patient mentally cancer, patient gets depressed postoperatively. If you ask them a month or two at home, no one is getting back to normal life. But here, minimal invasive is so fast recovery, they are confident improves, get back to routine life. That is much more advantage. I will go one by one cancer, how that then you can design laparoscopy robotic. And complete mesocolic excision. And here, and T3, this is what we wanted to have. I used to create a tunnel, and see, you can look at, this is a, see, this is a root of the mesentery we incise, and we go making between the gyrotous fascia and the mesocolon, and after that coming back, this is another way of modified approach, and the patient is getting back complete clearance of the nodes, infrapancreatic nodes and gastrocolic nodes group, and take it that way. Lymphadenectomy is example look at, and this is ileocolic vessels, and you can see we go clearing the SMV completely, so that, and this is ileocolic artery, this is vein. Now mesocolon we will divide it and preparing it, anastomosis, see intracarpal anastomosis, and we can do very suturing very easily, there is no problem at all, and putting a linear jaw 6 centimeter echelon, side to side firing and making the suturing tension free. This type of surgery, no need for a drainage tube, no need for a Riles tube, the patient can be given oral fluid the same day of surgery, second day patient can be discharged. This type of surgeries, see, you can see suturing. Do you need for that suturing, one need a robotic to do it? And this can be very well and done here. Second thing, esophageectomy is the most dangerous operation, chest or highly, very high complication mortality. And transnasal esophageectomy, all known, is a modified oringus, was described open. Same thing can do laparoscopic very well. But of course, we don't recommend this now. Initially, I was doing it. Nowadays, everywhere we focus thoracoscopic esophageectomy because we are able to clear en-bloc esophageectomy, including clearance of the nodes along the right and left recurrential nerves. It can be anastomosis in the chest or anastomosis in the neck, and we can do triple staple anastomosis, wide stoma, tension-free, leak-proof. So stricture, future, no. So this type of things, it can be done very well laparoscope. Of course, it can be done robotic, I am not denying it. And that thoracoscopy esophageectomy prone position was developed by us and promoted across the globe. And when I published 130 cases 2000 and that shown in a live surgery in Hong Kong, that was a trend every world changed. Ergonomic comfort, double lung ventilation, single lung tube, no lung handling, wide mediastinal, and anastomosis, which I mentioned. So small video clipping, I want of time. See, this is XL trocar and connecting you to a 0-degree telescope, and you can see carefully passing it. Many of the cases there may be addition. Now look at, and these were lung collapse partially, still getting perfusion. And that's why this is, keep it 8 or 6, it is okay. You can see the bronchus and clearance. See, this is azygos arch and put a ligature. Now I put Abzolak clips. This is technique and previously we used to do it. Now you can look at thoracic duct, you can identify and see, you can work out the upper mediastinum, nodal clearance, aortic arch, all can be done well here. This is a technique, in fact, as now following in robotic, they call robotic esophageectomy nothing but it is a prone esophageectomy, and it is a laparoscopic technique has gone to robotic, and it is. But still, if you ask me, the nodal clearance, dexterity, yes, I am doing comparative study between esophageal laparoscopic robotic. If you ask me which is the first choice, I will robotic, particularly for left recurrential nerve and right recurrential nerve. Rest of the steps laparoscopy is fine. If you use a 3D laparoscopy now, it is available with a rotatable tip Olympus and no need for it. And Karl Stoss, there is a 3D 4K vision that you use it now. I don't think vision disturbance between this and the robotic. It is Medtronic using robotic and this one camera only. So again, this is where. So another thing, gastrectomy, esophageectomy, how minimally invasive you look at here. This patient had advanced cancer, radiation chemotherapy given, stomach and esophagus involved. So after total gastrectomy and esophageectomy, I am doing a right ileocolon, putting it in substernal and taking the ileum to the neck and anastomosing it to the neck. Ileum going to the esophagus anastomosis, it is a very good accepted procedure. We were the first to do it. Now you can this like this we can doing it. So this is the patient for third day, an ICU sitting it, you are showing how nice that gentleman. Now it is almost 2.5 years over, is doing very well. So this prone esophageectomy when developed, it won Sages Award. Also live surgery I showed at Hong Kong during ELSA Congress. And this when I published in JACS, then subsequently I was invited to Japan to go as a course director. From that time till now, this prone esophageectomy laparoscopy is the gold standard. And even the UK where I have not studied it even a single day, but I was invited to perform show live operation and they conferred honor fellowships. Radical gastrectomy again now it has become much more laparoscopic robotic and it is all choice. And reconstruction technique is much important than this instrumentation. If one can do a triple stapling anastomosis in the esophagegastric and there tension free and wide, that is much more than and this. Of course, I don't say nodal clearance, it has to be done. See, portal vein, common hepatic artery and celiac axis, hiatus, and this kind of clearance has to be there, no doubt about it. But again, reconstruction technique is much more important. So, and see, we introduce a stapler jaw and make it a side to side, then anteriorly closing it. One can use a stapler also across linear anteriorly, making a quadrangular diamond shape. That is also works very well. It is all possible. So Whipple operation is the most complex operation, and I will show a small video how it is been keeping camera to right umbilicus, systematic and synthetic excision, extended coccus maneuver can be done well, and I have my own gem rubber band attraction technique which I will show in the video clipping. See, this is subhepatic exposure, just a sling, decompressing gallbladder. Okay. and see gallbladder retracting up, and see colon is mobilized down, and I am doing a coccus maneuver, and look at this, IVC, aorta, taking the infrarenal nodes, aorta cavity for sampling, also suprarenal, left renal vein, you are appreciating it, take the nodes cranial to the left renal vein, and taking the paraceliac and lateral to celiac axis, and you can, this is a vision, you can see how nicely laparoscopy going, and this is a 2D in fact. If I do a 3D, 4K, imagine it is something is much more than. See, now I have a rubber band traction technique, using it onto the divided neck of the pancreas and colon. Now you look at here, systematic uncinate excision, and see that SMA, because of traction it is pulled to the right side, and this SMV and portal vein is pushing to the left side. Now you get posterior anterior to the uncinate, and it is lying because of the rubber band traction. So this kind of clearance, whether you do robotic or not, the same technique one can do it, that is much more. This is IPDA, and anastomosis, look at here, and same reconstruction I do in laparoscopic robotic, I study together, and outcome is same, leak rate and this, and modified Blumhardt anastomosis, we doing it, and go to transpancreatic and seromuscular anastomosis. You look at this duct to mucosa, one can doing it, and and here same way if you look at coccus maneuver. See, I am doing robotic, the same type of things we do in laparoscopic, and when you do same and outcome is same, I don't know why you want to spend for a company. Last few years, whatever I did robotic, I worked for the company earnings, and we lost a few crores of rupees for that purpose. So when we published 42, first time laparoscopy 42 cases, it was the largest series, laparoscopic. Then subsequently Japanese asked me to write up. Again, 10 years experience I brought in. And this was a live surgery held at open laparoscope Whipple proved superior, and he himself, Buechler, accepted, said on the stage. And this was robotic, Tang was doing robotic, I was doing a laparoscopy at Hong Kong. Finally, he himself said, and maybe Palanivelu coming by bicycle, I am coming a Benz, the outcome is same. So this is there, and we did a comparative study, again showed, published in British Journal of Surgery, laparoscopy hold. And only guidelines was lacking behind, for which we did a consensus guidelines for Whipple. It is called Coimbatore Submit, published in Surgical Oncology. Pioneers from world over came to Coimbatore for these guidelines making it. So now, even a cirrhosis liver, with energy source so available, one can do Whipple. In present cirrhosis, it can be done laparoscopy robotic. And age group, now there is no end degree, but it's a performance status of individual. Even at 93, we have done a laparoscopy Whipple, so that is way makes it. Even a cyst, 12, I did a 10 centimeter cyst in a girl, and just 3 months before marriage, after 2 years, she delivered a baby. So these were faster, quality of life better. After all, I am talking why, no? These Chinese people said Indian model suits China because we developed a cost-effective models that is, till that time they were not for advanced, subsequently doing extremely well. That's why they honored at their 30 years age. And these were the pseudocyst pancreas, splenectomy, I did it at Bombay, and not even 12 hours, they were walking across the airport coming to. So today I want to tell, and we surgeons need to learn technique, no doubt about it. And technique is getting improved, and high success rate now. Technology you can't ignore. We need to learn. Well, laparoscopy also consider technology, robotic surgery also. Whatever the best suits our community, we have to take it. So we need to learn both laparoscopy, robotic, and currently it is a people surgery. Laparoscopy is people surgery, even available rural India. I am very thankful for our Indian surgeons for adapting it so cost-effective manner. Robotic surgery, till now it is a corporate surgery and has to be used selectively. Future, I am also open mind, and new technology like artificial intelligence, something like imaging, all will come. That day we will change. Currently, young surgeons are available in the forum. I tell you, kindly learn both laparoscopy, robotic. Just some surgeon says robotic is the best, don't look at go. It is not. Today even flights available, business, economy class available, but still economy class is the largest section of people traveling, business limited. One can have a chartered flight, go to different cities, one city or another, but 99% people we have to go by regular transport, flight or train. So I conclude saying laparoscopy is the most wanted for GI surgery currently for Indian setup. Thank you.